Hi, everyone. I'm Lucy Cohen. I'm excited to be kicking off tonight's virtual journal club hosted by the SPD and Pedra. Our format today is to have a Q&A after each presentation. So please put your questions in the Q&A box in Zoom and not the chat. Dr. Nessa Agazada from Mayo will be introducing our first speaker and article.
Hello, everyone. Welcome to the SPD Virtual Journal Club. It is my total absolute honor and pleasure to be inviting our next speaker, or our first speaker for the night. Dr. Bernard Cohen truly doesn't need any introduction for his numerous contributions to the field of pediatric dermatology. So he will be talking to us tonight about Tinea capitis, in particular focusing on one of their most recent publications in Pediatric Dermatology Journal. And the title of the paper is Management of Tinea capitis in Infants and Children in the United States, a National Survey of Pediatric Dermatologists. So we are all so excited and also very eager to hear and learn from you, Dr. Cohen, about this absolutely important topic, not in our everyday practice as pediatric dermatologists, important for our patients and public health. So please.
Anyway, I'm just going to say is that you can read the paper, but the Pedra study was focused on asking what pediatric dermatologists did, in the country, and I would say that most do what we do, but we tend to be a bit more compulsive in terms of many of them do not look at other members of the family to look for diagnoses and see if we can find a source. Some of them do get cultures, but not all of them. But again, pediatric dermatologists we're kind of cool because we have Woods Light in the office, and we have a dermatoscope, so we can often look and make a diagnosis more specifically based upon some clinical findings without sending a culture. But again, one of the things that I do recommend, and that not all pediatric dermatologists do, is send a culture. I do think that's important to confirm. Anyway, let's just do our 7 or 8 minute talk here just on the. Anyway, so Tinea capitis. I'm going to show you some images, but we're going to show you some non-inflammatory tinea capitis, which we call sort of black dot ringwormers. Some kids will present with a seborrheic dermatitis-like clinical pattern. I'll show you some images. And this is also often a trichophyton species. Sorry about that. Then there's inflammatory tinea capitis. It's often, you can leave it there, often microsporidium species. The kids will present with inflammatory papules, pustules, and crusts. They carry on as a really intense inflammatory reaction. And I'm going to show you, I'll show you these images. I don't want to run out of time here. Anyway, here's a kid with what I think a lot of people would call black dot ringworm. This is classic sort of trichophyton species. You get little black dots, and you get the hair tends to fall out. You see acneiform lesions sometimes on the forehead, like you see here, and it's not incredibly inflammatory. This is sort of classic, probably one of the most common presentations. And some kids will present with with some inflammation that can be localized. Seborrheic dermatitis is not going to be localized like this to two little L-shaped passages. This kid on the other areas of the scalp was completely normal. So that's what derm can fool you. But again, this is one of those presentations that can sometimes fool you. And if you see something like this and it's localized to an area like this, you should be sending a culture or doing your dermatoscopy or whatever. Again, tinea capitis early. This shows an early lesion that, some broken off hairs, and there's some mild inflammatory lesion here. Here's a seborrheic dermatitis-like presentation. I think this was not misdiagnosed by a pediatric dermatologist, but by a pediatrician, because these little patches, these little circular coin-shaped lesions did pop up. It was diagnosed initially as an atopic dermatitis or seborrheic dermatitis, which is a common presentation, especially if it's a little bit inflammatory, but not terribly so. Just to remind you, this is what I always torture people. I always say, please point to me and show me where the skin lesions are in this tinea capitis. And most people point to this area here right behind the ear. Again, this is sort of your classic black dot ringworm. It's not terribly inflammatory, and it's also spread to an area up here. So if you looked up here, you'd see this endothrix, which one of the things to keep in mind is trichophyton. If you got your dermatoscope out, the lesions, the inflammatory lesion, the lesions, the organisms tend to hang out inside the hair shaft. It's important to recognize that because that's classic for trichophyton, which accounts for probably 75 or 80% of all the tinea capitis you're going to see in the country, in the U.S. And it's interesting because terbinafine, it's not new, but it's relatively new compared to griseofulvin, actually is a really good drug to treat endothrix because it tends to stay the organ it tends to the antifungal tends to stay inside the hair shaft, which is perfect for this. Okay, and here's a kid who has more inflammatory lesions. You see here, there's inflammation here and inflammation here. You can see quite a bit, and you can see here that this is an ectothrix. You can see the organisms hanging out. It's actually outside the hair shaft. And this is much more, this is classified for microsporum, and this is actually M. canis. And it tends to be more inflammatory. And again, it tends to be ectothrix. So you get your dermatoscope out and you can look, you make the diagnosis. And there's actually evidence that greasy-fulvin is maybe a better drug for microsporum, although microsporum species only account for about 25% or 30% at the most of tinea capitis in the US. Okay. Here's an inflammatory. This is actually a kid who had this for a while. It was like a black dot. He's had some other black, and again, he developed this intense inflammatory eruption, which we refer to as a carry-on. And this kid, actually, I treated him for a week or 10 days. In addition to the antifungal, I used some prednisone because one of the things I do worry about is that this skin that's so inflammatory that when it heals, you can get rid of it with the antifungal, it can leave a scar. So you got to be careful about, is this intensely inflammatory kind of lesion? Okay, here's an inflammatory tinea capitis in a light-complected kid. And this turned out to be microsporum. And people don't realize that microsporum is often it's acquired from animals. So dogs and cats, probably in the US, cats probably more inflammatory more commonly. And I just wanted to show you this. People miss this all the time. And just a while back, we actually had a paper, here's back in 2011. This is a kid who had subtle black dot tinea capitis that everybody missed. But this kid developed a dermatophytid, sort of a subtle eczematous kind of eruption on the face and the upper back. And when we saw this, I said, let's look at the scalp. And we looked at the scalp and we saw classic lesions for black dot ringworm. I gave this kid a little topical steroid for the areas that were itchy here. And we put this kid on an oral antifungal, and these lesions eventually disappeared, but they lasted for two or three more weeks. Okay, so tinea capitis, it could be a subtle diagnosis, especially if it's with a trichosporum that accounts for the majority of lesions you're going to see. Most common in kids from 3 to 7 years, but it occurs in the younger and the older. We've seen it in parents. 15 to 20% of African-American school children, this is in a Philadelphia study, were diagnosed at some point with tinea capitis. Transmission from scalp to scalp and fomites, because again, if kids share hats and in the house and they things that touch the scalp can get you into trouble. You have to be careful. Go to a barbershop. I think now, again, it can be subtle and people can miss it. These kids need to have oral therapy, examine close contacts. We did just because people. I think a lot of pediatric dermatologists, when we did that survey from Pedra, they actually said that they don't always look at other family members and other kids. We did a study in Pittsburgh. We found that when we looked at least one parent, tried to get two parents, at least one parent and other children in the family, 50% of the families had at least one other family member where we cultured them and had a positive culture. So again, no sharing of hair grooming tools. Children on treatment can attend school. Because a lot of kids were kept out of school for 6 to 8 weeks when they were started on treatment. So Ajax, microsporum species are more common in boys. Trichophyte and tontrans are equal in boys and girls. 80%, 75-80% are trichophyte species. It's more common in African Americans. Again, peak insights at 3 to 7 years. It occur in young and old. When I say adult women, when we looked in families and cultured family members, parents and other family members, when we got positive cultures, it tended to be in the moms. And inflammatory lesions can sometimes resolve spontaneously, but again, that may be an urban myth because I would tell you this is that it can be something you have to be careful about. Trichophyte and tontrans can persist for long periods of time, and it can be not terribly inflammatory, which is why it's an issue, and it spreads readily in the household into other kids. I'm not going to bore you with details here, just to say that greasy-fulvin, has been used for a long time. Microsize, I'm not going to bore you with this. You can look at, but greasy-fulvin microsize, ultra microsize is more effective. It'd be what I would recommend. The problem with greasy-fulvin is that it requires treatment for a long. We were actually treating for a long time. Like 10, 15 years ago, we were using it for 10 to 12 weeks. I think now the recommendations, I would say with greasy-fulvin, you probably should be doing at least 6 weeks. and maybe sometimes, again, with Microsporum canis, in these kids, you might want to, again, Microsporum species actually tend to respond better because Griseofolvin loves the outside of the hair shift, which is where Microsporum species sit in the endothrix. Terbinafine granules are cheaper, they're easier to get, you can use them for a much shorter period of time. They work best with trichophyton species, and you can only need to treat for 4 to 6 weeks. And so I recommend terbinafine for trichophyton species, and I would suggest Griseofolvin, which account for, again, only 10 to 15 to 20% the most. Especially in babies, and I'll show you some real quick one before we finish. There's pretty good evidence that itraconazole and fluconazole really do work well and can be used for short periods of time. In infants, actually, itraconazole and fluconazole are approved for treating Candida sepsis, and there's good data on its safety. So again, I'm not afraid to use it in the young kids. I mean, if we have a paper out there, which you may see in the bigger paper that looked at that. Okay. Okay, so we did study 200 kids for tinea capitis. The majority, I wanted to see the kids that went to the emergency room. This is actually at Hopkins. The kids who went to the pediatric emergency room, how many that were seen in the ER, how many of them actually had, when they thought that could be ringworm, how many of them sent a culture? And it turns out that almost none of them sent a culture. One of the things we tried to teach the pediatricians is, I don't care if you even suspect it, even if you start treatment, get a freaking culture. And the practitioners, pediatric practitioners weren't, they're probably more familiar now with terbinafine, but they're still probably using Griseofolvin, which is probably not the drug of choice for trichophyton species, which account for the majority of infections. Just a quick thing. We actually have a paper where we reported three newborns who had tinea capitis. These were kids under 2 weeks of age. We treated these kids with itraconazole, fluconazole, because again, it's approved for treating Candida in preemies and newborns, and there's really good data to show that it works extremely effectively in treating tinea. So consider oral fluconazole or itraconazole, 5 milligrams per kilogram a day for 6 weeks if you see it in the first couple of months of life. And again, if for some reason you're having problems, and even in the older kids, there's no question that they're easy, they're safe, they're effective. It's off-label and probably require a shorter period of time. So if you're worried about them not following through for 4 to 6 weeks or 6 to 8 weeks, fluconazole or itraconazole would be a drug of choice. And here's a 2-week-old. So in one of the pediatric clinics, this kid had 5 scalp lesions, looked just like this. Again, predisposing factors, large family, sources of infection, large family size, low socioeconomic status, crowding. We had one adult, one other. I told you we found it positive cultures. Barbershops, movie theaters, schools, daycare. Zoophilic species come from family pets. So again, if a kid comes in and has a Microsporum species, you might want to talk to them about getting the cat or dog to the vet, or even, I mean, we used to bring them in. We used to sneak to their house and kind of get a culture. So in our neighborhood, kittens are the main source for Mem canis, which accounts for the majority of Microsporum species, which may be as high as 15 or 20%. In a rural setting, M. gypsian is a Microsporum species that hangs out in the soil. So kids who spend a lot of time in the garden, or kids who live on a farm, this might be something to think about. Okay, state-of-the-art review coming. Again, you might want to take a look at the Red Book of Pediatrics. Again, but terbinafine, I'm not going to bore you with this. We already talked about that. So organisms are everywhere. The epidemiology varies with the body, the site, the age, and sex of the patient, geography, and the time. Sources, again, majority are coming from humans. And the majority we're seeing based on the data out there supports that African Americans win. The Microsporum species, not always, but often acquired from animals, like rarely from soil. It could be a carrier state. And we talked about treatment, public health measures, and the advantages of the newer antifungals. Better stop. I think I did my 12 minutes.
Thank you. Thank you. This is amazing. Kind of like a full-on recap and update on tinea capitis. We do have one question I was hoping you could answer from our audience, and that says, how do you differentiate black dot tinea capitis from trichotillomania in the absence of scaling and lymphadenopathy?
Well, here's the thing is that if you don't, well, again, what's interesting about the tinea is that tinea is often with the black dot, you're often still going to see a hair shaft there, but the hair shaft breaks off at the surface. But the kids are pulling their hair out, there's not going to be, you're going to have areas where there's no hairs at all. The other thing too is that if you look very carefully, you're going to tend to see a little bit of inflammation. And the other with black dot, the other thing is you get your dermatoscope out and you can see if it's an endothrix organism, but you'll see it in the hair shafts. You can actually see it. You can do a KOH if you're suspicious. If it's microsporum, you could use a Woods light and see if it lights up, which with microsporum it will. But again, you can easily get a little KOH, get your dermatoscope out, and you can play games and you can look at it and like. Well, yeah, my wife's saying a trichotillomania is not as even again, but you're going to see these little black dot. And again, when the black dot areas get a little bit bigger, you're going to still see the hair shafts in the middle. You're just not going to see bald areas of scalp like you're going to see with trichotillomania.
Fantastic. Thank you for answering that. And then another question. How about topical antifungals for tinea and newborns? What do you think of that?
The problem with topical antifungals is that, well, again, we didn't talk about topical antifungals in the other kids too. I sometimes will have kids use a topical, not a topical, but like I'll have them use some peeling agents on the scalp to hopefully get the scale off the scalp. I think will reduce the risk of them spreading it in school or whatever. I have them do stuff like that. Topical antifungals in newborns. The problem is that it will work sometimes, but probably more than 50% of the time it's not going to work. And if you have a kid in the family like that, you may end up spreading it around, whatever. So, and people don't make the diagnosis as quickly in those kids. So even with the pediatric dermatologist, they may not think about that diagnosis in the 2-week-olds like we were worried about. So again, I think it's not going to work. The other thing is itraconazole and fluconazole are so incredibly safe. They're approved for use in kids and preemies with candidiasis, and there's good data to show safety. So I don't have a problem again, if you have a kid that's under 2 months of age, I wouldn't hesitate but to use fluconazole or itraconazole because I think one, it's safe, there's good data to show safety, and it works incredibly well. And again, if you're in a bind and you have a kid who's 6 years old and has tinea capitis, and the parents are not compliant, and you're worried about the kid not doing it, you may be able to treat them with itraconazole or fluconazole in just 2 weeks and eradicate the infection.
Excellent. Thank you so much for those great answers. And then do you have a preference on what diagnostic tests you do, like fungal culture? What type of tests do you do?
Okay. Well, here's my recommendation is that even if you listen, if you pediatric dermatology, you got a dermatoscope, you can certainly look and see if it's ectothrix or endothrix. You can see the organisms, and you may be, again, based upon whether it's endothrix or ectothrix, you could probably diagnose whether it's trichophyton or microsporum. I would still send a culture to confirm it. Yeah, I would still send a culture, and the culture, if you have a good lab, they can get something back to you usually within a week or 10 days. The other thing is that when they send it to the lab, some of the labs that do cultures will also have somebody do a KOH, and you certainly could do a KOH in the office, and that would be a quick thing to do too. So if you're set up to do a KOH, you could do that. You can do your dermatoscope again, but I still think you can do those things. You could do a Woods light if you're thinking microsporum, but I still think that I would still send a culture to confirm it and to confirm the specific organism.
Fantastic. And then the last one, we'll move to our second speakers. Do you do LFTs in children for terbinafine or other antifungal oral treatments? Would you recommend that?
That's a good question. I have to say that I cheat because with terbinafine, I'm just treating for 4 to 6 weeks. And so if I have a kid, listen, you're going to get a good medical history. If you have a child who has some other medical issues, I'm going to check a CBC and a metabolic panel. Okay. I'm going to do that, period. If I have a kid who's otherwise healthy, I don't always routinely do that. But if they're completely healthy, if there's any question at all about any underlying disorder, especially renal or hepatic or whatever, I'm gonna check I'm gonna get a metabolic panel and a CBC, or at least a metabolic panel. Yes.
Thank you so much, and thank you for patiently answering all of our questions. Yeah.
And I can stop sharing so I can watch too, right?
Correct.
Okay.
Thank you.
Okay, well, it is my pleasure to introduce Dr. Shirin Bajaj. She completed her laser and Mohs fellowships with Dr. Roy Geronemus and is now an assistant professor at Sloan Kettering. She is here today to share her paper, Weekly Pulse Dye Laser Treatments for Port Wine Birthmarks in Infants.
Thank you so much, Lucinda. What a wonderful opportunity to present today. This was a paper that Dr. Geronemus and I worked very closely on during my fellowship. So it's wonderful to be able to present this today, and I'll be sharing my screen shortly just so you can see some of the images from the paper when I think it's relevant. So first, I just want to give some credit to Dr. Geronemus, who really has been one of the pioneers in this field, as somebody who had the courage to show that PDL really should be the gold standard treatment for port wine stains, and that early intervention with laser treatment when babies are even in their infancy, they can be treated without anesthesia, and that early intervention and aggressive intervention can inhibit progression and even decrease risk recurrence in patients who are less than 1. So this study we were basically trying to find out what's the ideal treatment interval in terms of how often to be treating patients. And just to kind of give you some information in terms of how Dr. Geronemus typically treats patients, before this paper, he was typically treating patients at 2-week intervals. And studies have looked at comparing 2 to 3 week intervals rather than 4 to 6 weeks intervals for port wine stains, and have shown that treating more often typically leads to both better outcomes and also decreases overall duration of treatment. But he had the idea to look at how outcomes would change or improve if we treated more often at 1-week intervals. And in terms of the rationale for kind of what made him want to try this, so first is that it just logistically, it's easier to to condense treatments when kids are younger. Because it's easier to treat them without anesthesia and just kind of to hold them down logistically. But others have sort of postulated that it might be that it might be more effective to treat people when they're younger because the vascular plexuses are smaller, and so it's easier to basically target vessels with less light scatter when the dermis is thinner in younger patients. And then leading up to my fellowship year, there was a paper that came out that showed some preclinical work that pro-angiogenic genes like VEGF peak at 7 days post-PDL treatment. And can thus inhibit the optimal therapeutic outcome. And the thought is that maybe if you intervened kind of like right around that period before repair and repopulation of incompletely destroyed vessels, that you might kind of have a unique window there to improve outcomes. And then finally, and what I think was really key was that anecdotally, Dr. Geronemus noticed that in the age group less than 6 months, when you're treating with PDL, often these patients basically don't develop post-treatment purpura, which otherwise require recovery of prior to the next treatment. So we thought that maybe if you make the treatment every week, particularly in patients who are not developing treatment purpura less than 6 months, if you start treatment early, you can basically like treat on a weekly basis without having to worry about PIH. So to our knowledge, this had never been studied before. I'll share my screen here so you can look at the demographics. Let's just see if this works. Okay, so this is a demographic table. This was a case series. So there were 10 patients that were treated at Laser Skin Surgery Center of New York between January 2022 and December 2023. Everyone was treated with the Prima at a spot size of 13 millimeters, affluence ranging between 6.5 to 8.5. We were treating to an endpoint of mild erythema and a pulse duration of 1.5 milliseconds. We were looking at effectiveness of treatment using before and after photographs, and basically 2 independent dermatologists graded the photos before and after treatment. Of the 10 patients that were treated, the vast majority, 8 were Fitzpatrick skin type 1 and 3. We did have 2 Fitzpatrick skin type 4 patients. All of the patients who were treated had treatment initiated less than 6 months of age, and the range varied from 5 days to 5 months. The majority had large birthmarks greater than 40 centimeters squared, of which 3 of the 6 were larger than 200 centimeters squared. And 7 patients had birthmarks on their face only without body involvement, but 3 had lesions involving the trunk, as well as the upper and lower extremities. And basically what we found was that at a mean time point of 2 months, the vast majority of patients at that time point had achieved either near total clearance or total clearance of their port wine birthmark. And that was basically with once weekly treatments for 2 months. And I'll just show you an example of one of these patients, of 2 of these patients here. There were 3 other patients. So of the 10, basically there were 3 that showed marked improvement at the time point of 2 months, and all 3 of them ended up going on to also achieving near total or total clearance by the end of the study. And then importantly, reviewers had asked us, sometimes you can see physiologic lightening of port wine birthmarks during this time period. And so I just wanted to mention that we did have internal controls in hair-bearing sites, which you can see in these photos. And you can see that the hair-bearing sites did not lighten. So I think it's reasonable to assume that the lightening was from the laser treatment. And none of the patients in our study had any kind of adverse events, including pigmentary alteration, scarring, burns, or infections. And I'll just show you another photo here. Another kind of thing that we were very excited by was, you can see in this image here that even areas and types of port wine birthmarks that are otherwise challenging to treat, so very large birthmarks, as well as port wine birthmarks involving the centrofacial location and the extremities, which are typically harder to treat. We saw really good results, so this would need to be studied further, but we think that maybe intervening early on especially challenging locations may actually improve treatment response in these patients. And I'll just show you here, there's an image of the lower limbs, which are typically very difficult to treat. And we can open things up for questions.
All right, thank you so much, Dr. Bajaj. That was a really, really cool paper, and I'm really glad that you're here to talk about it. We have a lot of questions. We'll try to get through as many as possible. Caitlin Peterman asks, do you change the settings with each treatment, or do you repeat settings until you no longer see a clinical response before changing?
So basically, as long as we're still achieving the treatment, the therapeutic endpoint, and as long as the patient is still seeing improvement, we do not adjust settings typically. But if at any point we feel like either the patient is plateauing in terms of improvement or we're not achieving the endpoint anymore, then we will adjust the fluence accordingly. And sometimes pulse duration. In these patients, we didn't really adjust the pulse duration, but the fluence in these patients we were adjusting.
And how much did you go up by each time?
So it really varies based on the patient. So I don't want to say it's not really like a one size fit all, but our starting for most patients, there were 2 Fitzpatrick skin type 4 patients. But assuming Fitzpatrick skin type 1 through 3, and every machine is different, but for the Prima, our kind of like go-to starting point was 7.25 joules at 1.5 milliseconds pulse duration and 13 millimeter spot size. And our go-to kind of adjustment would probably be like 0.25 joules of increase, but it's sort of like case by case, and it's hard to really answer that question.
Okay. There's a few questions about insurance. So someone has asked any problems with insurance getting backed up? And
Yeah, we actually did not. It's a good question, and we did not have issues with insurance. But we treated a small number of patients, and I don't know if since that time Dr. Geronemus has treated more, but to my understanding, there were no insurance issues.
Was it because people were self-paying, or did insurance truly cover?
No, so he does charge insurance for these.
Okay, cool.
Yeah.
A few questions about the endpoint being mild erythema. Do you recommend going down on the effluence if you're getting purpura?
It depends on the age group. So we did find that if we were treating kind of past the 6-month mark, we would start, and it was kind of like a sliding scale. But you start to see purpura come up as the patients get older, and then we wouldn't adjust the endpoint unless there was like a concerning endpoint that we were seeing. And sorry, we wouldn't adjust the settings, but when the patient came back, we would treat around any purpura that were left over.
Okay, great. And then Joseph Lamb asks, with older literature showing redarkening of port wine birthmarks 10 years after treatment, do you think this will happen to your patients as well?
Yeah, so we don't know is the short answer. There is evidence to suggest that if you treat people less than 1 year, that recurrence is less likely. But I don't think that we have enough information to really know that these patients won't recur as they get older. I do think that there's reason to believe that if you're able to target the vessels better and faster in this time period, that the risk of recurrence is lower. Like, I think mechanistically, there's a reason to think that if you're able to like eradicate, the lesion in its entirety, but I just think it's sort of like speculation.
And I think I'll ask 2 more questions and then leave the rest for you to maybe answer in the Q&A box. Lionel Berkovich asks, what did you use for topical anesthesia in the infants treated weekly?
So in that age group, we actually don't use topical numbing because they're a little too young. The risk of is methemoglobinemia. So we didn't use any topical numbing, but although they do cry, they recover very, very fast. And so it's really almost within like a minute of being treated, they're back to their usual selves, which is also kind of the benefit of treating in this age group.
Right. And then last question we'll ask live is, I note 2 type 4 patients. How much dyschromia happened with those patients?
None. And actually, I'm trying to see if we showed one of them. Okay, yeah, so we did not show, we don't have images of one of them, but we had no dyspigmentation in the type 4 patients.
Okay. Actually, I'm wondering if we can go a little bit longer. Can we do 5 more minutes of questions? Is that okay?
Yeah, absolutely.
Okay, cool. So Joy Shu asks, could you shed insight on how the laser recovery has been as well for the babies?
Yeah, so it's really like it's basically like you have 60 seconds of them crying, and then like honestly, like within 60 to 90 seconds, they forget that it happened and it's done. In the older age groups, you will get like post-treatment purpura, and then it just takes some time for that to go away. But really in this age group, it's almost like immediate in terms of just them going back to being their normal selves.
Lauren Pravini asks, for lesions with a larger area, were you treating the entire lesion at every session, or did you partially treat the areas in a serial way until it's cleared and then moved on to a different area?
Yeah, so I think there was 1 of the 10 patients where it was done serially because there was so much body surface area involved that it couldn't just all be treated together. But all the rest of them we had treated all at the same visit. And Yeah, it just sort of depends on like the patient's and the parents' comfort in terms of if they're able to kind of withstand the whole treatment, or if it's just too large and you want to split it up.
And so does that mean the parents are in the room during the treatments?
Yeah, the parents are, so typically the parents are in the room. We have like 2 nurses, a fellow, Dr. Geronemus. And so it's kind of like a team effort in terms of holding the babies down. And but it's also like very fast. Like it's like depending on the site, like even, sometimes within 60 seconds you're done.
And a few questions about settings. Do you use a different starting setting for birthmarks on the extremities versus the face or more stubborn areas?
So in these patients, we use pretty much the same settings, yeah.
And do you adjust the settings for FITS4?
Yes. So lower fluence. And this pulse duration, sometimes you adjust the pulse duration as well, but at this pulse duration, you're okay, typically.
Okay. And Caitlin Peterman asked, when do you change the fluence versus change the pulse duration?
Yeah, so there's no like exact science to it. You're kind of playing around with certain settings based on what you think is going on. Like if you think now you want to target a different size of vessels, you may adjust the pulse duration. So it kind of just depends what you think is going on or why the patient might be recalcitrant to your treatment if you're plateauing. Yeah.
Okay. And then someone asks, I know you treat scalps. Do you find that there's hair thinning when they're older with the scalps?
I don't think that it's never been formally looked at. So I don't think we have any reason to think that there is hair thinning, but you do have to be careful in terms of like, usually we don't actually treat the scalp. We did start to play around with ways to adjust the settings to try to start getting at hair bearing sites. So like we did treat eyebrows. We started to treat eyebrows towards the end of my fellowship year, and we were playing around with, putting some kind of like a I'm trying to think of what it was called, not like a Sergi lube, and basically treating over that and lowering the fluence and adjusting the pulse duration, but we didn't quite, and we got to a place where we didn't feel like the hair follicles were being affected, but we didn't feel like the treatment was as effective in those areas at the settings that we were trying. So I don't know if Dr. Geronemus has optimized for that yet, but you do have to be careful in hair bearing sites.
Lionel Berkovich asks, how did you protect the eye?
We use eye shields.
Okay. And can you comment on the use of the Prima laser as opposed to other PDLs?
Yeah, so the benefit of the Prima is just that you have a larger spot size, so you can treat faster. And also, there's reason to think that it's like a more effective version of a PDL and has better technology. But taking that out of it, like your standard V-beam is sufficient. It's like a little bit slower at a 10 millimeter spot size, but it's definitely sufficient.
Okay. Well, thank you so much, Dr. Bajaj. Those are all of our
Thank you.
questions. Really appreciate being able to ask you them live today.
Thanks.
And I'll hand it over to Dr. Ploss next.
All right. Thank you, everyone. I'd like to welcome our next speaker, Dr. Terry Greiling, who hails from OHSU, where she serves as the Associate Professor of Dermatology, among other roles, including Associate Program Director of Research, Vice Chair of Dermatology, and Director of Telehealth. We're very excited to have you here today to discuss your recent publication entitled Guselkumab for Pityriasis rubropilaris and dysregulation of IL-23, IL-17, and NF-kappa beta signaling. Thank you so much, and welcome.
Great. Well, thanks so much to all of you for inviting me and for being interested in PRP, because that always makes me really excited. Let me share my, is it going to let me share? Anyone good at tech support? Trying to click through to get sharing. Oh, it wants me to quit and reopen. Okay, I'm back and I'm going to try again. I think it's going to work this time. Sorry for that delay. Okay, here we go. So we did a trial looking at guselkumab for PRP. This was an open label trial. It was an investigator initiated study, which basically means that I made up the trial and collected all the data and then worked together with our team to publish it. But the maker of guselkumab didn't have a role in that other than to give us free medication. So we treated patients at the FDA approved dosing for guselkumab. We gave them 4 doses. So the last dose was at week 20. And then we judged their efficacy at week 24. And then we stopped the medication and looked at sustained remission at week 36. So this was an adult study. So I appreciate you asking me here today, but I do think that it is relevant for juvenile PRP too, and I'll say a little bit more about that in a few minutes. We enrolled 14 participants. This was, as I said, open label, so everybody got drug. 12 completed this study. 1 was lost to follow-up. He just wasn't getting better and he decided not to show up for his last visit. 1 died in this study, which we thought was unrelated. So he got a severe burst of gallbladder, which led to sepsis and then MI, and he was deceased from that, although he was getting a lot better with his PRP before that. So of our 12 patients that completed the study, more were male, most were white. The mean age was 56 years. So that all really reflects the adult onset type 1 PRP population. Their mean baseline BSA was mostly erythrodermic. Their mean baseline PASI was 30. So if you're familiar with the Psoriasis Area and Severity Index, it's quite high compared to a standard psoriasis study. Their mean baseline DLQI was 20, so very severe impact on quality of life. Mean baseline itch, 6.9, mean baseline pain, 4.7. So again, I think this really reflects what it feels like to have PRP. And most had been on a prior systemic therapy and failed, though 2 were treatment naive. And basically, clinically, they got better. So if we're looking at the graph on the left, this is measuring their severity based on, so it's the clinician assessed severity based using PASI. So all these numbers go down. On average, the PASI improved by 62%, and their DLQI also improved by 62%. So those nicely reflected each other. And so at week 24, 9 out of 12 had at least a 50% improvement. PRP is, with these medications, is very slow to respond. And so there's a lot of hand holding and kind of waiting for it to get better, but then it often does. And then we looked at sustained remission. So of those 9 patients who were better at week 24, we followed them up at week 36. And at that point, 8 out of the 9 were 75% better and 6 out of the 9 were 90% better. The mean PASI had dropped from around 8 to 2. At that point, the study was designed to have people off the medication. So 4 of them agreed to stop the drug and wait and see what happened, and that went well for them. 4 were too afraid to stop drugs, so they stayed on an IL-23 inhibitor outside of the study. And then 1 actually decided to switch back to a TNF inhibitor. So this is where it's sort of a clinical tip for PRP. I think with that sporadic onset PRP, if they get to that 90% better mark, then I encourage them to stop their biologic, and usually they do well. If they get a lot better, but not that good, a lot of them will need to stay on it, and maybe they have the type of PRP that does not go away spontaneously. But I really think that if we think about PRP as this, usually people suffer horribly for a few years and then some of them spontaneously get better, that this biologics will shorten that to maybe 6 months of suffering. So it's a shortened duration, but they can stay clear off of the biologic. So in the context of how we treat PRP, this is the way I think of it. So before we started using biologics for PRP, these are the response rates. So these numbers are from 2 systematic reviews from 2019 that were nicely done. Acitretin, 36% response. And again, all these are not actually controlled trials. So it's like 36% got somewhat better, but hard to measure what that means. Methotrexate, 33% response, cyclosporin, 11%. Prednisone basically does nothing for PRP, which is, I think of as a diagnostic clue. And it's not clear why you can't treat PRP with a steroid. So traditional immunomodulators just aren't that good for helping people with PRP in many cases. And so in my opinion, IL-17 and IL-23 pathway biologics really should be considered as first-line therapy for PRP and people who can do that. So of course, they're approved down to certain ages in kids, but not the little ones. But in the studies that have now been done, so I did an ixekizumab study published in 2020. We had a 66% PASI 50% improvement. There was a secukinumab study that came out in 2022. They saw a 73% percentage of people got 50% better at least. And then the guselkumab trial is showing 75% got 50% better. And then there are a lot of publications that have proposed ustekinumab for familial PRP, really thinking about that as first line. And whether that's specific to ustekinumab or you can use your other IL-23 biologics isn't entirely clear. I think probably all of these biologics work well. Then looking at it from an omics pathway, since we did that in this paper too, we did transcriptomics on lesional skin compared to age and sex and body location matched healthy controls. And it kind of showed the usual suspects that we thought would show up. So as an example here, we're looking at IL-17 signaling pathway genes. The darkest red on the left is the baseline of people who would later go on to respond to the IL-23 inhibitor. The lighter red next to it is the baseline patients who would not respond. And then the still lighter red is the responders at week 24. And then there's the non-responders at week 24 who basically didn't get better from week 0. So what you'd expect to see. And then NF-kappa B, of course, is implicated in familial PRP, which I'll say another word about next. And similarly, I think sporadic PRP and familial PRP really do share an inflammatory pathway. So it was, highest in people who would respond to this and then lower in non-responders and then improved the most in people who got better with therapy. We did proteomics analysis too, and also sort of confirmed known, but interesting target. So IL-8 has come out, which is a neutrophil signaling molecule, has come out as really high, one of the highest, very dysregulated in people with PRP. It gets better with therapy. CCL20 has been proposed as a biomarker, and I'll come back to that. IL-17C and IL-12B came up as one of our highest. So that's a place where, gosh, does it matter if you use Stelara versus Tremfya here? Because ustekinumab is also targeting, of course, the IL-12 in addition to 23. And so maybe ustekinumab has advantages there. Although you'll see these are patients treated with guselkumab and the IL-23 or IL-12 went down. So it probably works either way. And then we tried to, of course, tease apart, what happened with the people who didn't get better? What's different about them and why are they not responding to guselkumab? And so what we saw is really that people who responded to therapy had kind of elevation in a lot of different innate and adaptive inflammatory pathways. But non-responders just had less of those inflammatory pathways and more sort of keratinocyte proliferative pathways predominating, almost more like an ichthyosis picture rather than a psoriasis picture. And so that's still kind of the question in my head. Gosh, is PRP really a couple different diseases and some more have this ichthyosis type, inflammatory milieu, and others have more of a psoriasis type inflammatory milieu. And I don't think you can tell by looking at them. There was all these Griffiths categories that categorize them by morphology, but I really don't think that corresponds well to treatment response and inflammatory activation. Again, my opinion, but that's the data I've seen. This slide is, again, comparing familial PRP to sporadic PRP. So this figure is based on a mouse paper that came out in 2018, where they took the gene mutation found in genetic PRP and knocked it into mouse skin. And they saw, so it's a CARD14 mutation. CARD14 goes in and activates NF-kappa B, which turns on CCL20, and that activates this IL-17, Th17 type inflammation. So that's what the mice showed. That's what the genetic mice showed, and that's what our human sporadic PRP patients are showing too. So again, I think there's a lot of parallel in the pathways, and then again in the treatment options for both genetic and sporadic PRP. And then I'm going to take the last minute to plug another paper of one of my friends and collaborators in Switzerland. So they just published this a few weeks ago and treated patients with IL-1 inhibitors. They only had 3 patients, but all 3 of them responded within 2 weeks. So that is far superior to my trial in terms of response time. And so this pathway that they're showing, that I put the figure in here, basically they're saying IL-1 is that upstream signal that's turning on NF-kappa B in the sporadic PRP patients and leading to that feedback to the Th17 cells. So I have not had the chance to use this in my patients yet, but I'm really curious to do so. All right, so I'll stop talking and happy to answer any questions.
Thank you so much. That was really wonderful. A few questions. How do you choose whether to use an IL-17 or IL-23 biologic? Is there a certain phenotype clinically that leads you to one biologic over another?
Yeah, great question. I think that 17s and 23s are pretty similar in terms of efficacy for PRP as they are for psoriasis. And so I will take anything I can get my hands on, basically, in terms of, insurance authorization and access. I don't have a strong opinion. I think the 17s are slightly faster for PRP as they are for psoriasis, though it's still glacial speed for PRP. So I'll talk through both of them with patients and again, take what I can get.
And as in this paper, it appears that the dosing was psoriasis dosing. Is that typically your strategy? Do you stray from psoriasis dosing? Do you find that that's needed in certain patients who are partial responders or non-responders? Or do you move to another drug?
Yeah, I again, that's sort of a question of what do I want versus what can I get. So there, one of the patients in our IL-17 trial, again, so when doing a trial, the FDA will only let me use the already approved dosing, or at least that's the way I went through rather than doing an IND. And so, so off the trial, I had one patient who got better, but he was actually considered a non-responder. And then with his home dermatologist, he doubled his IL-17 dosing. He went back to the every 2 weeks of ixekizumab rather than once a month. And then he really got better and it came down close to normal. So I think that these people are erythrodermic. Their levels are super through the roof of these cytokines, and that sometimes more blockade is better. It's just hard to come by, and I don't, I'm at a university, I can't get samples. I usually have to stick to the approved dosing.
Thank you. And what is the role for systemic retinoids? I know you mentioned that in terms of the inflammatory milieu, some of the non-responders looked maybe more ichthyotic. Is that a scenario where you may not have that information? Are you adding a low dose of systemic retinoid to your biologics?
Yeah, I do tend to, in clinical practice, sprinkle in a little acitretin, especially when the hands and feet are miserable. And then when they have a chance to get better, take it off again. And again, I think that when I say responder and non-responder, what's interesting is that the responders will almost clear or completely clear, but even the non-responders will get 30 to 40% better on the biologic. And so, and when we don't have anything else, though, again, I'll add a retinoid too, absolutely, is the answer yes to your question. But I think even the non-responders in the trial have some improvement and improvement in their quality of life on the medication. So a lot of them will choose to continue it, even if they're not clearing.
And then lastly, how does the presence of CARD14 mutation affect management, or does it affect your management? I think of ustekinumab as having a lot of publications indicating that it's effective, but that may not mean that other biologics would also be effective.
Yeah, I agree. And I don't have data. So all the patients in my trial, in my 2 trials, have not had CARD14 mutations. We've checked them and they've all been not had any gene mutations that we can detect. And that was done with collaboration with Keith Choate at Yale on the paper. And so I still reach for ustekinumab for genetic PRP because that has the most evidence. And again, when I'm fighting with insurance companies to get it, I can reach for that publication and recommendations that are out there. And I think ustekinumab is still a good drug for both genetic and sporadic PRP. And I don't have the clinical experience in treating genetic PRP with many other biologics.
All right. Well, thank you so much. That was wonderful. We really appreciate you sharing your expertise, and I'll hand it back over to Dr. Cohen.
All right. I just want to thank our fabulous speakers today for sharing their research with us, our moderators for picking these articles, and the SPD and PEDRA for hosting our audience, for attending and asking such thoughtful questions. These journal clubs happen quarterly, and we hope you can join us again. Thank you.